English and it is Manchester English. So if you have difficulty with my accent, don't be embarrassed to put your hand up and somebody will bring you a headset. Okay? I have a headset in case you ask me any questions in Italian. Okay, Professor Pirelli, thank you for that. I think that explained very well the clinical benefits of ECP. And we heard a lot this morning about the importance of investing in technologies that deliver growth in incremental value. So in this session, I'm going to talk about whether the cost of that incremental value of ECP is worth the investment, both in terms of patient benefits and also in terms of benefits to the hospital. And I'm also going to talk about affordability because I think it's budget control that keeps the hospital manager awake at night, and I can sympathise because I've not slept very well myself recently, so we'll cover that as well. Okay, so let's look at the cost of incremental value first. There have been a number of economic studies now which demonstrate the economic value of ECP. The first one I'll show you was a UK study, and this was for cutaneous T-cell lymphoma. It's a type of hematological cancer that manifests in the skin. And the incremental value of ECP in this study versus standard care was negative, meaning that the ECP treatment was dominant, i.e. it cost less, and also it delivered greater benefit. Another study on ECP, which is just about to be presented at the American Apheresis Society next week, actually. And this was a study that looked at overall response as an end outcome, and the last study looked at life years, so it was an incremental gain in a year, the cost of a gain of a year of life. So this is response. Now, if you look at this, this is ECP, and these are alternative drug therapies. So you can see there that ECP is lower cost than all of them, apart from interferon alpha, which is the one at the bottom. The benefit of ECP is greater than interferon alpha, and also, although if you look at the cost and benefit together, there is an additional cost to ECP in effect. Interferon alpha has a very short response time, so the duration of response is usually not more than 6 months, and then the patient has to go on to a different therapy. So next we'll look at GVHD, Graft-versus-Host Disease. This is acute Graft-versus-Host Disease. This was a study done in Poland, and the incremental cost-effectiveness ratio of an additional life year was 24,000 zloty. So in Poland, the threshold for cost-effectiveness is actually 33,000 zloty. So in terms of government payers, they will consider this a good return on investment. We also have some studies looking at chronic GVHD. So we have two referring to adult patients, and both of those studies, one in Poland and one in the UK, show a cost-effectiveness ratio for lower than the current national thresholds for investment in those countries. So the one in Poland looks at the cost of an additional life year, and the one in the UK looks at the cost of a QALY. So, as you know, that's the combination of incremental quality of life and an additional life year. We also have, in Poland, they looked at paediatric patients as well, and again, that's well below the cost-effectiveness investment level expected. Although monotherapies are very seldom used in real life, for academic purists, it's quite useful to look at one therapy versus another therapy because it's easier to control the study, obviously. So here in Spain, the authors looked at ECP versus rituximab and ECP versus imatinib. Sorry, imatinib is the correct word. And what you can see there is that against rituximab, ECP costs more, but the incremental cost-effectiveness ratio, the incremental cost, is well within the threshold for investment. And against imatinib, it's actually dominant, i.e. cheaper and more effective. So that talks to the benefit to the patient. But as you know, and as several people have mentioned earlier on, the cost of care is not just about the direct cost, and all those studies that I showed you before just looked at the direct cost of treatment with a drug or with ECP as a therapy. What they didn't look at was the impact of those treatments on the patient care pathway and the cost to the hospital from an annualised budget point of view. So, because we know that patients with these autoimmune diseases or allergenic diseases are really very much immunosuppressed when they're on alternative drug therapies, and therefore, as Professor Pirelli mentioned, they are much more susceptible to serious infections and complications. The drugs are quite toxic, so they can get very sick, and often it's the treatment that will ultimately kill them rather than the disease itself. So we have to look at the cost of that. So any therapy that we choose has to be considered in the context of the overall impact on the patient. So what we did was we ran an audit at a London teaching hospital, and we looked at the rate of hospitalisations and also the utilisation of high-cost drugs to treat serious infections. So the hospitalisations were for complications of GVHD, in other words, the treatment wasn't controlling the disease very well, or serious infection caused by immunosuppression. So you can see from this chart that if the blue is what actually happened, that was audited, and this was 10 patients. So that was a significant amount of money that these patients were costing the hospital and the payer. They were in hospital for long periods of time, they were in and out of hospital, and they also spent substantial amounts of time in intensive care, which is even more expensive and has not been factored into this table. So if we look at the published data on ECP, we can make assumptions about, because it reduces the dependence on immunosuppressive drugs, and because the response rate is high, we can make a sensible assumption that the expenditure on hospitalisations and high-cost drugs should reduce. This is backed up by some of the published data and some unpublished data that we have access to on things like infection rates. So we have the Grimes paper in 2000, which showed that before patients were put onto ECP, and these are patients who failed steroids, 60% of them had serious infections. And then after they were put onto ECP, none of them had serious infections. Then we have unpublished data from Peter Taylor in Rotherham, which is in the northeast of England, which is one of the biggest treatment centres in Europe. They've been doing a study there for 2 or 3 years. It will be published very soon. But personal communication from Peter tells us that his data shows a 50% reduction in serious infections in the first 6 months of treatment on ECP, and a further 50% over the 12 months, the next 12 months. We also have a study by Elan in 2004 that showed the connection between reduction in dependence on immunosuppressants and reduced hospitalisations. I can also confirm the results of an audit that was carried out at a different London teaching hospital recently on patients with acute GVHD, and that's just about to be published as well. And what we saw there was we looked at patients on standard care and we looked at patients on ECP. Now the difference here is these weren't monotherapies. These were, you know, the patients on ECP had immunosuppressants and the patients on immunosuppressants had combined therapies. So this was real life. And what they found there was that the patients on ECP had 21% less hospitalisations because of course the period of the acute disease is a lot shorter than it would be for chronic. But also a 48% reduction in high-cost drugs. Okay. So, are these results good enough to persuade a health technology assessment agency to say that payers should be investing in this type of technology? Well, this is a list of recent reviews done over the last few years on ECP. They looked at all the available data, and all of them have approved ECP for acute and chronic GVHD. Also in France and the US, ECP is approved for reimbursement for solid organ transplant. And in some countries for other indications. What's interesting is that ECP is only, or photopheresis, is only approved for reimbursement in 2 regions in Italy. So although doctors often do it, they do it under pressure because it's not reimbursed. So what we'd like to see is reimbursement in all the regions in Italy, so that there's not a perverse incentive to select a treatment option that is reimbursed but is less effective and costs more. Professor Priori also talked about the online versus the offline system. So the bar at the above is actually the online system, which is the closed system where the patient just gets attached to the machine, everything happens in one go, and then the patient can walk out of the hospital. With the offline system, there are multiple steps in the process, and the patient has to have blood back removed from the patient, and then processed, and then the patient gets the blood back. So that's a bit more convoluted, and under the EU directive for cell manipulation, you've got to have a laminar airflow cabinet for the offline system, and it's got to be done in a grade D sterile room. So there are other things to consider other than the cost of the procedure. What happened was at the Policlinico Tor in Rome, we did an evaluation of the online versus offline system. And the result of that evaluation was that by using the online system, the treatment time was reduced to 115 minutes from 221 minutes. That might not sound like a long time, but for the patient, when he's sat around in the hospital, it means a lot. So, in reality what happened when they used the online system, it resulted in 47 extra bed days freed up on the apheresis unit. It also resulted in 70 days of freed up doctor time and 76 days of freed up nursing time. Now in a very busy unit that's under a lot of pressure and has possibly waiting lists, difficulty fitting patients in, that's delivering great value for money. It's just not all about cash, it's sometimes about capacity and managing demand. Did it cost a lot more? No, it cost 4.4% more. So if we're talking about growth in incremental value, that sounds to me like pretty good value for money. So, just to summarise, this particular therapy is one of those things that makes good clinical sense, but it also delivers a good incremental value at relatively low cost, and it seems to be affordable.